Hi everyone, welcome to the seminar series. The seminar series was presented to you by the Center for Communicable Disease Dynamics and the Harvard T.Chan School of Public Health. My name is Siyang, and I will be your moderator for this session today. And I'm really excited and honored to welcome Professor David Potel as our speaker today, who is at Yale School of Public Health. So just a few standard logistics before we start. So this seminar will be recorded. So please turn off your camera if you do not wish to be recorded. And the recording will be available on YouTube and on our CTDD website at a later time point. So throughout the talk, you can send questions via the chat function to Laredo. And please specify if you would like to ask your questions directly. We will ask you to turn on your camera and unmute yourself once we are ready to take questions. All right, so now I will introduce our speaker. So Professor David Potel is a professor in the Department of Health Policy and Management and the co-director of the Public Health Modeling Unit at Yale School of Public Health. So Professor Potel holds a PhD in operations research from Yale University and has been a faculty at Yale since 1998. So his research focuses on designing and implementing policy models and cost effectiveness analysis with the general objective of promoting a reasoned approach to decision-making and resource allocation in public health and medicine. So he has a special interest and expertise in HIV and has published broadly on the cost effectiveness of testing, prevention, treatment, and care. But today, I believe we'll hear more about SARS-CoV-2, which has been an important research focus for Professor Potel since the beginning of the pandemic. So the talk today is entitled Policy Modeling for SARS-CoV-2, Screening, Prevention, and Vaccination. So thank you so much for joining us, and please take it away.
Thank you very much, Siang. It's really nice to be here among so many old friends and also some very old and treasured heroes. I have no need to get through all my slides, so please do interrupt and send us off on tangents as you see fit. Passover has come early this year. We're going to ask 4 questions that touch on COVID screening and vaccination and prevention policy. And if we don't get through them all, that's just fine with me. But the questions that I thought I would use to structure this are things that I've been working on of late. Is there a safe way to open residential college campuses in the fall of 2020? Second, armed with the knowledge that we acquired in 2020 and the availability of a safe, effective vaccine, is there a way to achieve a safe return to normalcy on residential college campuses in the fall of 2021? Third, what would it cost and what might we get if we actually mailed rapid antigen-based tests for SARS-CoV-2 to every household in the United States? And finally, there's an old adage among vaccine policy experts that vaccines don't save lives, vaccination programs save lives. And bearing that in mind, what are likely to be the key drivers of COVID-19 vaccination program success? So what do these 4 questions have in common? Well, each was the topic of front page coverage in major media outlets during 2020 and 2021. Each involved trade-offs between competing clinical and epidemiological and economic considerations. And each demanded a policy response long before the major uncertainties surrounding the question could really adequately be resolved. And so, for temporal reasons and ethical reasons and logistical and financial reasons, it wasn't possible to address any of these questions using the more traditional forms of health and medical investigation. And what I want to present to you today is my effort to address those 4 questions using the methods of decision analysis and state transition modeling, sensitivity analysis, and cost effectiveness analysis. And each of these papers is available for download at the URLs you see here, and I've shared them with Siang, who's going to put them in the chat. And I'll be very happy to share these slides as well with the organizers. And so, as I said, I'm actually hoping that we're going to run out of time before I run out of slides. But if you're interested, just read the slides that I share and reach out to me if we want to talk about anything. Before we get started, I do want to acknowledge my mentor, Ed Kaplan at the Yale School of Management, because this talk is really in the spirit of the things Ed schooled me in, the methods of what he calls policy modeling. Simple, first strike analyses that focus on timeliness and meeting the decision maker wherever that decision maker happens to live, emphasizing how operations affect performance, and aiming to home in on the essential considerations that matter most for decision making, rather than trying to just cram in as many descriptive phenomenological features as can possibly be squashed into a model. In short, quantitative analysis, but with qualitative insight as the guidepost rather than precision. And while I'm acknowledging the giants on whose shoulders I'm standing, I think I should also acknowledge my collaborators, Paul Sachs at the Brigham and Women's Hospital and Harvard Medical School, who just this week was named the new editor-in-chief of Clinical Infectious Diseases. So that's pretty cool. Professor Jason Schwartz, my colleague at the Yale School of Public Health, Rochelle Walensky, who at the time was at the Mass General Hospital when we conducted these analyses, and Amy Zhang of the Harvard Medical School. And while we're at it, let me just acknowledge the National Institute on Drug Abuse, which very graciously permitted me to broaden and bend the aims of an existing HIV modeling grant to support this work. So, special thanks to NIDA for that. Okay, question one. Is there a safe way to open residential college campuses in the fall of 2020? We were approached in May 2020 by a consortium of Boston-based college presidents to define the performance standards of a virologic monitoring program for SARS-CoV-2 that might permit the safe return of students to campus. The question they were really asking was, is there a way that we can safely reopen our doors in the fall of 2020? And can we understand how varying the assumptions about the severity of the epidemic and the frequency of screening might affect total infections, and also how much isolation capacity do we need to set aside? And while we're at it, can you tell us how much this might cost and help us to wrap our heads around the idea of value? Right, Encore? Pretty cool, right? We got to talk about value to university and college presidents. But just to be clear what the boundaries around this were, right? This was not an assessment of population-wide screening for SARS-CoV-2. We focused very narrowly on the students returning to campus because that was where these college presidents' primary duty was. Not entirely, but for the most part, we ignored the impact of reopening on staff and faculty and the surrounding community at our peril, and we'll talk more about that. But very, very briefly, this was a simple analysis designed to be accessible to these college presidents, built on a very simple SEIR modeling scaffold. There's your S, there's your E, there's your I, and there's your R, I guess, to which we added the availability of regular repeated screening, both here with a test of imperfect sensitivity and specificity. So we had some false positives, which we sent to isolation along with the true positives. You could also end up in isolation by developing frank observable symptoms. So we created a new compartment for the uninfected persons receiving a false positive test. We separated the infected compartments to distinguish between undetected asymptomatics and detected asymptomatics, true positives, and observed symptomatics. We included a lag time between the time of test administration and the time that a report was actually received and acted upon. So there was a delay between this arrow here and this arrow here. And finally, over and above the epidemiology of transmission, we also permitted an additional number of new imported infections via what we refer to as exogenous shocks. Transmissions to students by university employees or members of the surrounding community, super spreader events such as parties and stuff. So these are infections above and beyond those which might be predicted by the simple dynamics of an SEIR model. So the implementation was super easy. With a model this small, it actually fit in an Excel spreadsheet. To assist the, and here are some of the input data we used. Basically, we were relying on the Centers for Disease Control, which had published a guidance document with recommended pandemic planning scenarios. And to the extent possible, we adhered to that document in parameterizing our analysis. So we defined 3 increasingly pessimistic epidemic scenarios. You see them right here, the best, the base, and the worst cases. with effective reproductive numbers running from 1.5 to 3.5. And we use this model to estimate both cumulative outcomes like numbers of tests administered and numbers of true positives and false positive test results, numbers of new infections, person days requiring isolation. And we also estimated economic performance, cost, incremental cost effectiveness, budget impact during an abbreviated 80-day semester running from like Labor Day through Thanksgiving. And we assumed a medium-sized college, target population of about 5,000 students, all of them younger than 30 years old, non-immune, living in a congregate setting. And I think we seeded this population with like 10 undetected asymptomatic cases just to get things started. Now, these were the inputs we used, but if you don't like this, if you don't like what you see here, just go to this website where some really cool doctoral students at the University of Wisconsin-Madison reproduce the whole thing in R, and you can tweak every single input value and reproduce our numbers or try your own numbers out. But let me show you what results we got using our base numbers. Briefly stated, we found that, yes, indeed, there was a safe way for students to return to college in the fall of 2020, and that the key element of that plan was routine, high cadence, asymptomatic screening of the entire student population at a frequency of like every 2 to 3 days, coupled, of course, with strict adherence to social distancing and other basic prevention practices. So this first set of figures held an important qualitative finding. Here you got the base case, the worst case, and the best case. In each case, though, what I think it shows is that the frequency of testing matters more than the accuracy of testing. Within reasonably sensitive and specific and conditionally independent tests, frequency is what matters. Under all three of these epidemic scenarios, testing every 3 days, which is the blue line in each graph, with a 70% sensitive test over here on the left-hand side, outperforms weekly testing, that's testing with the gray line, with a 100% sensitive test. So you would rather use a less sensitive test more often than a more sensitive test less often. And that was true. It's also true that a 70% sensitive test performed daily produces fewer cumulative infections than a 100% sensitive test performed every 3 days. So first and foremost, frequency of testing, the most powerful variable at our disposal. And we weren't the only ones to arrive at this finding. Beautiful paper by Dan Larimore and colleagues of yours, right? Several of you at TH Chan on this beautiful paper. Another one by my colleagues at Yale, including Ed Kaplan, all arriving at basically the same conclusion, which is that testing frequently while minimizing the delay from testing until isolation for those found to be positive. Those are the two most controllable levers for preventing large residential college outbreaks. Okay, that's insight number one. I'm going to show you a bunch of graphs that look like this to show you how test frequency affects isolation capacity utilization. So an isolation dormitory needs to be big enough to house not only the students with symptoms and not only the students without symptoms who have received a true positive test result, but also the false positives, right? And this figure depicts the number of students in isolation over the 80-day semester. And this is in the base case with an effective reproductive number of 2.5. So you've got the true positives in dark blue, the students with actual symptoms in light blue, and the false positives under a program of daily screening. And here you see that the cases of infection, the dark and light blue areas, are held below about 25, but daily screening also produces a large number of false positives. That's the gray area. And so you could argue that this is a depiction of what happens if you test too much in this population. Here's that same graph again up here in this corner, but now I'm showing you it in the upper left, and then less frequent screening every 3 days, screening weekly, and no screening at all, just symptom-based identification of cases for isolation. So with less frequent screening, the number of false positives fall, but the number of real infections, of course, rises. And by the way, note carefully that the vertical axes are not the same, right? They're getting bigger. So testing every 3 days holds both true and false positives to manageable levels, but testing less frequently, well, this is here you've got an outbreak, and here you've really lost control. And if you're wondering, by the way, about this scalloping, those are the exogenous shocks that are taking place on a 2 or 3 day basis. And so they're creating these little mounds. This is in the base case. If the reproductive number is lower, like in the best case, under the most optimistic conditions, weekly screening should be enough to control an outbreak. But even under these optimistic conditions, you can't get away with no screening at all. Reliance on symptom-based monitoring, we gamed out thousands of scenarios, and we did not find any circumstances, plausible circumstances, under which relying on symptom-based monitoring alone would be good enough to control an outbreak. Basically, we found that any college that waits for symptoms to manifest before triggering a response is behaving like a fire department that waits for reports of that the house is burnt down before actually responding to the alarm. So you still need some screening even under the base case, but it can be as infrequent as once a week. And of course, in the worst case, with the effective reproductive number of 3.5, daily screening would really be required to keep things under control. Anything less frequent than that, and you lose control of the infection on the campus. So they also wanted to know about value. So a really quick primer. Here's where Ankur can actually wake up if he wants to. Oh, Ankur, there you are. We tried to do a simple cost effectiveness analysis because they asked for it. I'm not sure the cost effectiveness criteria were really at issue, but they wanted to know. So we computed the incremental cost effectiveness ratio, and this is probably going to be familiar to most of you. It's just the delta between the cost of one intervention and another divided by the number of infections you get under those two strategies. So it's delta divided by delta reported in cost per infection averted. And the preferred strategy is the one that confers the greatest benefit without exceeding some maximum willingness to pay to avert an infection. And we got a rough and ready measure of the willingness to pay to avert an infection by simply taking the COVID-related mortality for both students of college age and the general population, the number of years of life that might be lost under those two different populations, using a very simple societal willingness to pay threshold of $100,000 per life year gained, and assuming that each infection averted would avert 1 plus the reproductive number secondary infections in the general population. And with that very, very crude, and I'm happy to defend this more if you want to, but with that very crude estimate of willingness to pay, here's what it looks like in the base case. With a reproductive number of 2.5, the willingness to pay is about $8,500 per infection averted. And what we find is, the more you test, so you're looking at increasingly aggressive testing as you go down the roads, right? Costs more, you avert many more infections. And if you compute the incremental cost effectiveness ratio, it turns out that quite robustly, the optimal, the most cost effective solution is to screen in this population every 3 days, which seemed to make a lot of sense, both in terms of what those previous graphs showed about isolation usage, as well as what we think we know about the generation time and the incubation time of the infection itself. So that seemed to make sense. And of course, in the best case scenario, you could screen a little less frequently. Weekly screening turned out to be the most cost-effective option. And in the worst case, screening every 2 days with a willingness to pay that's higher because you're creating more secondary infections. So to summarize, the optimal policy, depending on whether you're looking at the base, the worst, or the best case, was somewhere between weekly screening and screening every 2 days, probably every 3 days, which is what we recommended. And we were able to come up with estimates of what proportion of the overall student body would become infected over the 80 days with this regimen, as well as what it might cost per student. So the take-home messages for the university administrators was, yes, there is a strategy for the safe reopening of college in fall 2020. It hinges on routine, high cadence testing. Our best guess is that you probably want to test twice a week. We wanted to admonish them that symptom-based monitoring would almost certainly not be sufficient to prevent outbreaks, even under the most optimistic circumstances, and to remind them that isolation capacity was a precious resource, and that it was possible both to overscreen and underscreen. Shall I stop and just ask if people want to make, I see that there are 3 items in the chat. Siang, is there anything I need to worry about? Oh, you placed them there.
Yeah, this is just me pasting the link for the papers.
I actually did send a question forward if I can ask it now.
Bring it on, bring it on.
Yeah.
I was curious as to how you determined the R0 values for the best, worst, and base case scenarios. Were you basing them off of values in the country during peaks and troughs of the pandemic?
Yes, and those were the ranges that were suggested by those pandemic planning scenarios in the CDC guidance. So remember, this is all, May of 2020. Yeah.
Can I dive in here for a second, David?
Please.
I'm sorry, I joined late because of some problems, but so I, along with Jim Hammett, who I'm not sure if he's on, we're among, there's Jim. We're among the primary authors of the HHS guidance that you cite. And we also have a paper along with Mike Eber, who I'm also not sure if he's on, that has some values for non-fatal cases. I can try and share both in the chat, but I don't think our values are that different from what you just showed.
Thank you.
I'll try and put this in the chat and if I can figure out how to put the document in, but thank you.
Encore, edify us.
Glad you called on me. I thought you were going to chicken out. Could your model handle testing capacity constraints? Because right now, I think what your model assumes is you throw money at the problem, you could create more testing. I think the way it played out was actually testing itself became the scarce resource, at least in the short run. Could this model handle that? I mean, I know others can, but did you think about that? Any of your models do that?
This model cannot handle that. This model assumes that if you want it, you can find it. And this analysis and this consortium of university presidents was actually the one that worked closely with the Broad Institute. God bless the Broad Institute for making test availability essentially infinite for any a school within driving range of Cambridge. So the quick answer to your question is no, the model can't handle it, but I don't think it was an unreasonable thing to assume almost infinite testing capacity. Did I say thank God for the Broad? Yeah. All right, I'm sorry, David, go for it.
Yeah, I have two questions. One is over the subsequent year and a half or 2 years, did you have a chance to see if your model was accurate? Did you go back to college situations and see if the numbers of cases that you thought you would see actually occurred?
Yeah.
And the second question is, putting all those false positives into a dormitory filled with true positives, I was just wondering if you took into account the fact that it could lead to higher infection among the false positives.
Right. Okay. So with regard to follow-up, we have written a couple of papers on what happened on college campuses, what worked and what didn't work. It is more difficult than we imagined to really tease out the causality there. But it does appear that colleges that adhered to a policy of high frequency testing coupled with seriously assiduous adherence to non-pharmaceutical interventions were net importers of infection rather than net exporters of infection to their campuses. And there isn't a whole lot of evidence of major outbreaks on any campus that was conducting high cadence testing. That isn't to say that there weren't plenty of schools that didn't test that did just fine. There were. But I think that most of the cataclysms that we're aware of, like the ones at UNC Chapel Hill and Wisconsin-Madison and the University of Michigan and elsewhere, were all places that weren't testing with any, we're not conducting any routine asymptomatic testing. As to the question of false positives, and we were deeply concerned about just what you're talking about, right? Students and their parents freaking out about being put in isolation, infection jail with, actual infected students. As it turns out, if one thing didn't materialize, it was the false positives. The test turned out to be much more specific than anybody anticipated. And false positives were just not a big part of the isolation capacity census at any of the schools that I followed up with. So while we were concerned about it, I can't tell you what the experience was because it wasn't, it proved to be a non-issue. But you have given me a nice segue. So I'm going to thank you for that, because I'd like to forward to 2021, because as you can imagine, the question of how to keep campuses safe arose again this past fall. It was a slightly different question because it happened against the backdrop of a dramatically more favorable context, what with the widespread availability of multiple highly effective vaccines and evidence demonstrating the considerable benefits of testing and non-pharmaceutical interventions. So this past fall, the question facing residential college officials wasn't so much whether there was a safe approach to bringing students back onto campus, but rather whether we could help decision makers to design and implement a portfolio of strategies, some combination of vaccination policies and virologic monitoring and non-pharmaceutical interventions that would strike what they considered to be an appropriate balance between adequate outbreak control on the one hand and restoration, let's call it the return to normalcy, the restoration of the residential college experience. And so question number 2, is there a safe way to balance outbreak control and a return to normalcy on residential college campuses in the fall of 2021? And so Jason Schwartz and I reworked the analysis in a paper that appeared in the Annals of Internal Medicine in August of last year. And the big feature of this paper is a really simple companion decision tool. Again, it's a spreadsheet implementation designed to be friendly enough that a college president can just access it. And recognizing that the ground was just shifting so quickly, and because context and risk tolerances varied so much from one college to the next, this tool was designed to give those decision makers a user-friendly way to, let's call it, choose their own adventure, and to evaluate the likely impact and interaction of the prevention and screening options at their disposal, to assess the feasibility and compatibility of the choices they were making, and to explore alternative options. So, motivating our approach here was really to give them something that they could use to help them make more informed decisions. And we were motivated by the contention that college decision makers express their beliefs and their priorities and their preferences regarding campus safety and operations by the choices they make on 4 dimensions of decision making: the vaccine coverage level they choose to set on their campus and the degree to which they actually mandate it and enforce that mandate, the frequency and the targeting of their asymptomatic testing program, both to vaccinated and unvaccinated students, their tolerance for infection on campus, how much infection are they willing to endure and consider a not unreasonable level of infection, and finally, the trade-off of safety versus normalcy on campus. So the role of our decision tool was to help these decision makers actually answer those 4, make their choices and state their preferences on those 4 dimensions, and then to help them recognize whether in fact those choices and preferences were compatible with their objectives. So let me show you how it worked. The first thing we asked them to do was to set the rate of vaccination on their campus. So rates of college, vaccination varied very widely this past fall, mirroring differences in both coverage across the United States, as well as the degree to which schools encouraged or enforced vaccine mandates. Colleges that elected to do nothing were nevertheless able to observe, population vaccine levels close to the population level, like 50%. But more aggressive approaches, mandates and incentives and exemption policies, all yielded vaccination rates well in excess of 90%. I think the value at Yale College was over 99. I think the value you guys achieved at Harvard was in the 98.5 region. So it was possible to actually, set a vaccination coverage level. Obviously, some colleges were constrained by either politicians or community norms that railed against mandates, but it was a choice, and it was something that they could set in our decision tool. The second thing they could set was the frequency and targeting of routine asymptomatic screening on campus. So many colleges chose to mothball or retire their asymptomatic testing programs, and they only tested symptomatic individuals. Others elected to maintain their programs. Some elected to distinguish between vaccinated students and unvaccinated students and to screen some students more frequently than others. We made those all decision variables within the decision tool. So you could target screening at different rates or turn it right off, but at different rates to the vaccinated and unvaccinated population. We also gave them the opportunity to set all sorts of other assumptions about the epidemiology of infection in their community. Step 3, so we're at 3 of 4 now, set a tolerance level. How much infection are you willing to tolerate as a proportion of the overall population over a 120-day semester? It's unrealistic to expect that all viral transmission can be eliminated. So, what we tried to explain was that, it might be a credible thing to think that you could keep the cumulative number of infections below some ceiling. And here we asked decision makers to set that ceiling, to set a cap on how much infection they were willing to tolerate over the semester. Now, you can imagine that some administrators balked at the prospect of specifying an explicit threshold, but we tried to convince them that, in fact, the acceptable campus infections variable really was a choice, and that you could infer just how widely divergent different campus decision makers were in their response to outbreaks. If you look in the fall of 2020, Chapel Hill shut down and moved to online instruction within a week when just 200 out of 30,000 students tested positive for coronavirus. Contrast that with Wisconsin, Madison, a similar student population, but which remained open over the entire year, despite the fact that they had 900 positives in a single week in September and over 7,500 cases over the course of the year. Or Michigan, a somewhat larger school, which had 3,000 or more cases detected on campus. So, our point was, this is a choice, and you ought to be able to set that choice. Okay, here's the last consideration, and it's probably the trickiest one. We asked decision makers to consider how much risk they were willing to tolerate in pursuit of this return to normalcy. So here on the horizontal axis, you've got a continuum that runs between total lockdown and unrestricted return to pre-COVID college campus activities at the other extreme. And we operationalize this safety versus normalcy trade-off by defining R star, the on-campus reproductive number prior to any intervention related to vaccination or testing, but subsequent to the adoption of any non-pharmaceutical interventions like masking and distancing. And actually, if you think this is squishy, you only have yourself to blame, because it was Alan Garber who actually talked to me and proposed this particular variable. You can see the email message he sent me. He basically said, my guess is that it would be worth increasing the intensity of testing if by doing so we could eliminate distancing or restrictions while maintaining a constant decrease disease risk level. So in other words, let's use a greater value of R and mitigate its impact by increased testing. And we bashed around ideas, and it was actually Alan who said, I think 3 is a not unreasonable number for what we're aiming for at Harvard. So, there's no data underneath this. I'm bracing Lisa for your question, where the hell did that come from? And the answer is it came from Alan. Okay, but we obviously did a lot of sensitivity analysis. But let me show you how this all gets put together. take items 3 and 4, the maximum tolerable threshold of infections and this risk to normalcy trade-off. And what it defines then is a green zone right here, where the return to normalcy can be achieved at a level of infections that is deemed to be tolerable. And now the decision model examines whether the vaccination and testing policy that you set in steps 1 and 2 is actually compatible with that green zone. So let's overlay steps 1 and 2. Here's what you get if you don't do any testing at all. You're not in the green zone. A college that can do no better than vaccination coverage of 50% and which plans to offer no testing, okay, is not going to be able to get itself into its desired green zone. The safety versus normalcy trade-off would need to be held down here at about 1.5 to keep infections below the 5% that they have set. Alternatively, the college could raise its tolerance for infections or adopt an asymptomatic testing program. So if they start testing like every 2 weeks, weekly, we're getting closer. Yes, we can attain the green zone with testing at least every 3 days with this orange line right here, okay? And this is what you get if your vaccine coverage level is 50%. If your vaccine coverage level is 90%, then you go from here, which is what I just showed you, to here, suggesting that schools that can achieve 90% vaccination coverage ought to be able to return to normalcy as defined at least by Allen as number 3 on the horizontal axis, and hold their infections below 5% of the student population with little or no routine testing. So I think the cool thing about this is that this is the link. You can try it on your own right now if you want, and you can play with the underlying epidemiological variables as well. But we gave the decision makers the opportunity to choose their own adventure, and we shared this tool widely. It was available as part of the publication. We actually received feedback from about 20 university reopening committees and college presidents around the country. And the overall response was pretty favorable. It was funny how many college presidents wrote to say that they found it addictive to play with. But they seem more ready to accept some of the general lessons than others. For example, they seem to be very, it seemed to resonate with them when we said, not one size fits all, and that an optimal plan for college reopening needed to capture the specific institutional attributes and preferences, as well as political and epidemiological circumstances in the surrounding community. So they were happy with this one. They also seemed ready to accept the message that the vaccination coverage was the key driver of safety. Obviously, most of the schools that I think were reading our paper and playing with our model probably had plans in place to impose and enforce mandates. But even the large state schools that were either forbidden or being pressured not to impose mandates recognized that this was a weak spot in their plan that would need to be addressed in some other way. There was less willingness to accept the suggestion that it might be time to scale back the routine testing programs. I mean, our model really did seem to show that there would not be much need for routine testing on campuses that could achieve vaccination coverage levels in excess of 90%. And I will say that by mid-November, when things were looking so good and before Omicron, words like overkill and let's look for an exit ramp were starting to be used, at least among the reopening committees that I'm participating on. But of course, Omicron put an end to that discussion. And of course, good to have a plan B that, given the breadth of potential outcomes in the face of uncontrollable and uncertain factors, even colleges with high vaccination rates really needed to be prepared to reinstitute or expand their testing. And I recognize that part of the problem is it's easy enough to toggle a masking requirement on or off. It's a much more complicated thing to toggle a testing program on and off. Once you mothball it, it's very hard to unmothball it. And I think that many of the schools just sort of said, you know what, we're going to keep it in place until we're really sure we're not going to want to bring it back. Encore, what do you want?
This is great. Can you go back to the graph with the green zone? Help me
Yeah.
interpret the vertical axis. waves go up and down, seasonality, outbreaks. What does that 5% mean? That's like the maximum percent of my campus at any point, or
No,
for the
cumulative,
semester?
cumulative.
Over the semester. Okay, got it.
Yeah. It's really this vertical one. I have no idea whether this should be here or here or here. But if you look at the graphs, like, I mean, assuming you're a 9, the size of the zone really doesn't matter. It's really, are you, at what point does your screening program become compatible with a green zone? So you're really just looking for what the cutoff level was. So while I really can't tell you in words what a reasonable value is, I'm going to play the I know it when I see it card. Don Goldman, what can I do for you?
Yeah, oh, thanks. This is really, really fascinating. I love the pragmatic, easily visualized approach. That's not often the case in work like this. So thank you.
Thank you.
I want to praise you for using the sort of maximal tolerable level, which is a very important societal question and a moving target. My concern is that when you say they, and you talk about leaders and you talk to provosts, they may not be fully aware about the fault lines or not fully consider the fault lines that this imposes. So a fault line for faculty is some of us, such as myself, are at a very vulnerable age, and what's tolerable for college kids may not be tolerable for us. And you right away set up an issue there. And then some of my own research with one of my fellows about the readiness of colleges to deal with chronic disease among their students was a little bit disappointing, to put it mildly. And there are students in the student body who are probably totally unaware in leadership positions with ulcerative colitis on biologics and so forth and so on. Certainly asthma is a big issue. So how do you build that in and reflect maybe on John Barry's note that he recently wrote, that in the 4th wave of influenza, people died like crazy, but nobody cared. And we do tolerate a lot of deaths due to influenza every year because it's just old people getting knocked off by the angel of death. So could you philosophize a little bit on that?
Wow. Thank you for that terribly important comment. You're right. The word tolerable is a very subjective one that probably changes dramatically whether your perspective is that of the college president, the student, the vulnerable faculty member, the member of the surrounding community. I think that the best I can say is that this is a decision tool that can show you how your policy might change if we raised and lowered that red horizontal line, so that we can see why it is that reasonable decision makers coming from different perspectives and taking differing views of what constitutes tolerable might reasonably differ as to what the optimal policy should be. I'm not sure that there's more that I can say other than that we tried to at least formalize that distinction.
Well, you could do it visually. So for example, you could parse out faculty members over 65 and show the similar graphics for that population, because when you showed the mortality, you did have a range, right? You had for college students, and I presume overall was including others.
Right.
And so they could see, so, okay, so if the old folk faculty come pounding into my office, here's the data for you and how it might look for you. I just wonder if that would be possible.
Right. So here it is. Suppose you have a faculty member who says 5% is absolutely intolerable. 1% is my threshold. So that person's line is down here. And clearly your policy of not testing because you're on the purple line is outside my range of what is considered tolerable. You need to be tested. From my perspective, you need to be tested more. Yeah.
Great. Thank you very much.
Thank you. I know it's an inadequate question. The other thing, and of course we can't say this, but at least on the Yale campus, our contact tracing would appear to show pretty unequivocally that we have had not a single case of classroom transmission yet. And if anything, the classroom is quite possibly the very safest place in Connecticut that a vulnerable faculty member could be. With a totally vaccinated, totally boosted and masked population, you are a bigger threat to your students than they are to you. As I said, I can't say that. I couldn't possibly say that.
That segues exactly to my question,
Yeah.
actually, because I was going to bring up transmission, because transmission is obviously important. This is an infectious disease. And I was going to say, if you have a situation where with the current mitigation strategies, masks and vaccination, ventilation, etc., you are not getting transmission, well, what do you do then? Because you kind of have this option that you can carry on with the masks and ventilation and you can be pretty confident you're not going to get transmission, and you can maybe scale back the testing. But if you scale back one of the other things and you're doing the testing and you find out what effect that has. It's a difficult question. I'm not claiming to have the answer to it, but I'd love to know what you think.
Well, I'm not sure I have an answer either, other than to say that, you know, I'm sure that you and I both agree that the Swiss cheese model of prevention is one that applies here. Not any of these interventions alone is perfect. It's riddled with holes, but the accumulation of these hole-ridden interventions proves to be a pretty impermeable block. And what we've got here is a decision tool that permits you to see how the inclusion or exclusion of different, you know, holy slices, you know, results in certain levels of transmission. That's not a complete answer to your question or your comment. But, you know, I think we've at least created a user-friendly tool that allows them to begin to think about which different, you know, accumulations of slices of those Swiss cheese actually produce a block as impermeable as they are tolerable, as they are willing to tolerate. Brenda Berman.
Thank you. I might have missed this earlier on, but does your modeling assume that the primary source of exposure is from within the college community? I'm curious about, I'm thinking of campuses that host large sporting events or arts events, and how exposure from transient general population access would influence things, or how it's covered.
Yeah, thank you. So in an attempt to recognize the possibility of those sorts of exogenous or imported infections, we overlaid on top of the standard epidemiological SEIMR model an additional layer of exogenous shocks that would take into account these super spreader events, off-campus fraternity parties, God only knows what have you. Do we really know the magnitude of those things? No. We are currently suffering through a spike here at Yale that is almost certainly attributable to a couple of really great parties that happened off campus. So we tried. I'm not sure how well we did, but it's in there. And if you think it should, I actually think, let me just go to that choose your own adventure. Yeah, right there. You could choose how frequently these exogenous shocks happen and how big they are, how many infections you import. So if you think our numbers, that we were being too cavalier and not recognizing how big those sporting events were as a threat, jack that number up and watch what happens. Yeah.
Awesome, thank you.
Rahul.
Thank you very much. I really like your kind of choose your own adventure tool. My question is about that reducing testing. You mentioned that that like one thing that's hard to calculate is like if you scaling back, if you eliminate a testing program because you don't need it, starting it back up again can be hard. Is there a way to sort of quantify that, you know, initial fixed costs so that you can see, you can include scenarios like, you know, what if a new variant emerges and you have to, like, is it better to kind of have like a bare bones scenario of testing, almost like, you know, when you have an old train line where passenger service is no longer needed, but you keep it there so that you can reintroduce it later. Is there, I don't know if you've looked at those kind of scenarios in your model.
So thank you. We did not. But it wouldn't be that hard for those of us that have become reliant on the Broad, because the Broad has been very clear. You contract with us up front, you buy a certain number of tests. The fixed cost in this particular case is very explicit and very well understood. So it wouldn't take a whole lot of work to do exactly what you're talking about, but we didn't do it.
Thanks, makes sense.
Tia, you've done a terrible job keeping me on track. I've got 10 minutes.
No, you can carry on. People have been asking questions, so it's absolutely fine.
All right, good. I've got 10 minutes. So there's no way I'm going to get to question 4, but let's just real quickly, since this is something that you guys have been leaders on, talk for a moment about what it would cost and what we'd get by mailing rapid antigen tests to every household in the US. I don't need to tell this group just how valuable rapid antigen testing might be to helping people understand whether they are actually contagious, infectious, and not just infected, and using those tests to stay home and potentially quarantine before they infect others. You know, when we published this paper in March of 2021, rapid testing was widely available and inexpensive in Britain, in France, Germany, elsewhere, thanks to government subsidies. But in the US, rapid tests remained expensive and in short supply. And while some of this was the result of a supply chain issue, a lot of it was also demand related. You all know that skeptics raised all sorts of objections, focusing their concerns on how well antigen tests performed and the behavioral response and poor uptake and imperfect adherence and false negatives, unfounded reassurance and false positives and needless isolation and work productivity. And, you know, we certainly were far from the first to tackle this problem or to show what the benefits might be of mass rapid testing. You know, an outstanding piece from the Galdani group here at Yale, a truly prescient piece from Michael Mina and Jim Stock at Harvard in October of 2020, for goodness sake. You know, and I can't say enough good things about you guys and Michael and your tireless efforts to make the case for expanded access to cheap and abundant rapid tests. I think we made an interesting contribution to that discussion by conducting a real decision analytic even if type analysis. So rather than trying to predict with precision what this was going to cost, we thought we might be able to take the skeptics on head first and bake every single one of their objections directly into our analysis. In fact, not just to bake it in, but to double down on their objections and to lean even more heavily than they did on the scales to bias the evaluation against mass distribution of testing and to see if we could make the case for mass testing, even if every single one of their objections turned out to be more than true. So our analysis, unlike the ones that you guys have produced, sort of said, look, let's assume that we mail these things to every household in America and 3/4 of the people take that mailing and throw it straight in the garbage, okay? And let's assume that then 75% of the people who, the remaining 25%, 75% of those people ignore the test result. They take it and they go, oh, it's positive. Well, the hell with that. Okay, so now we're down to what, like 6.5% or something of people actually staying home. And let's assume that on any given day, 1/3 of them say, ah, screw it, I'm going back, I'm dead. Enough of this isolation crap. I got to go to Ankur Pandia's class and start coughing up a lung. Okay, and then let's assume what? I got to get my shots in somewhere. You go to hell. Okay. Test specificity, you know, let's lower it and let's lower the sensitivity. And let's assume that it costs, you know, $5, even though Michael Mina says it ought to be possible to produce these things for 20 cents a pop. We put all those objections together. And once again, a really simple adaptation of the classic SEIR model, SEIR, with a set of parallel states to capture the impact of isolation. Again, super easily implemented in a simple spreadsheet that I'm more than happy to share if anyone's interested. But the overall story was that over a 60-day horizon, weekly testing under base case assumptions could reduce infections in the US from, I think we had 14.9 million to 11 million, deaths from 125,000 to 106,000. And although testing and isolation would increase the total number of workdays lost, individuals could expect to be isolated much less. I think it was like 0.17 day on average. So there wasn't going to be a whole lot of false positive workdays lost. And then, you know, if you compared and did the cost effectiveness analysis, the cost per infection averted would be about $5,400. Cost per death averted of 1.1 million. Even in the worst case, 3.2 million. Is that a big number or a small number? Here's where Jim Hammett may freak out on me, and I'm ready for him to freak out on me if he has to, okay? But Jim, I hope I did this right. I just took the value of a statistical life, which is all over the place. Oh no, what? Lisa, you're scratching, are you mad at me? I just said, look, let's take the lowest possible value they're offering us, 4.8 million. And I'm just saying, you know, I've got a cost per death averted of 3.2 million. So it looks like I've got a pretty good value here, even with all the assumptions I made, you know, about how bad this test works. So, you know, please chime in and tell me where I screwed up. But my bottom line was, don't let the perfect be the enemy of the good. Even a highly imperfect home-based testing program could confer an enormous amount of benefit, and that any retreat to more reasonable behavioral assumptions would only strengthen our results. I'm going on mute because I can see Lisa and Jim jumping out of their seats.
I'm not sure whether Jim's jumping, but you want to go first, Jim, or you want me to go first? I think for what you're doing, the trying to be conservative, this is a completely sensible and rational way to go about it. These are 2014 dollars. There are similar tables that are 2000.
Yeah, I inflation adjusted them. I did adjust them.
Oh, so I don't want to get too much down in the weeds, but there's a real income adjustment as well as an inflation adjustment. But Jim and I, in the other paper that I put in that was put in the chat, do have a long discussion about whether or not these values are appropriate for COVID, and basically come to the conclusion that there's a lot of uncertainty, but it's counterbalancing to an unknown extent. So using the central estimates as a default seems sensible.
Sian, can you be sure to send me that chat at the end, because I need to read that paper. Thank you.
But
Yeah, okay.
Jim probably got a better response than I do, so I'll shut up.
Jim.
I think what you did is great.
All right.
All right. Sorry, David. I hate to cut the discussion short, but I think we are running out of time. This is a really great talk. Like, there's so much. Yeah.
Yeah, I'm done. I'm done.
All right. Thank you so much for this terrific talk. And I think we can wrap up now. So on behalf of the Center for Communicable Disease Dynamics and the Harvard T. Chan School of Public Health, let's thank Professor Potel again for joining us today for a fantastic talk and questions. And also please get in touch with any of the seminar organizers if you have questions for us, or directly email David. Also, please check out the CDD website to stay up to date for upcoming seminars and other events. So next week's seminar will be given by Professor Wanda Marcotter from University of Pretoria, and she will be talking about our interdisciplinary approach to biosurveillance and understanding spillover from bats. So it's about bats. All right, so thank you again for joining, and I hope everyone have a good day. Bye-bye.
Thanks, everyone.
Thanks, David.